Welcome, everybody. Rush University Medical Center Division of Nephrology Renal Biopsy Conference for September 22nd, 2022. Today's CME activity code is 486529. If you have any trouble getting CME credit, just let us know. We have nothing to disclose, and our usual privacy statement is to ensure patient privacy is preserved, identifying information, and/or other details have been changed to disguise the identity of the patient and to protect the patient confidentiality. This was being recorded. It'll be uploaded on our YouTube channel. We're a little bit behind, but we're working on catching up. There's probably 100 there, so feel free to check them out. I see a bunch of new names in the list today. We all welcome new people. We love having everyone join. Get your friends. If you're not on our mailing list, send us an email. We'll put you on the mailing list. Join our YouTube channel. I'd like to welcome our applicants today. This is interview time, and we have 4 applicants. So welcome, applicants. Hope you enjoy it as well. The chat box is pretty much closed or the microphone is pretty much closed for everyone except the co-hosts, but put all your questions in the chat and we'll try to get to them. And with that, I think we're ready to go. Dr. Gashti has a great case today. Casey, you want to take over?
Yeah, sure. So our patient is a 58-year-old Black man with prior history of colon cancer, status post-sigmoid resection. This was about 13 years ago. He has reflux disease, chronic low back pain, and seasonal allergies. He presents to our emergency room with 2-month history of right flank pain and fatigue. He had also gone to the health center at his work and was noted to have a high blood pressure in the 170s and 180s systolic without any prior diagnosis of hypertension. He has been taking NSAIDs, naproxen 500 milligrams twice a day for his chronic low back pain. He reports very frequent urination. He almost has to go to the bathroom every hour. In the emergency room, his blood pressure was 168/94, and it was noted to have an elevated creatinine of 6.4, and we do have a documented creatinine of 0.9 1 year prior. His urinalysis shows trace protein by dipstick, but no blood, and with microscopy, he only had 1 red blood cell, 1 WBC, and otherwise unremarkable. CT of his abdomen and pelvis showed a 5-millimeter left stone contralateral to the site of his pain, with bilateral perinephric fat stranding. Initially, we thought that he had passed kidney stones, so we gave him IV fluids, and his creatinine did not improve. So in addition to starting a secondary serologic workup, we also performed a kidney biopsy. His Revio systems were significant for fatigue and right flank pain. His past history is significant for malignant colon polyp. He had rectal bleeding about 13 years ago, had colonoscopy, showed a polyp in the sigmoid region that was removed. The pathology showed malignancy, so he actually underwent a surgical sigmoid resection. He didn't receive any chemo or radiation, and he has not had any recurrences since. He has reflux. He takes omeprazole for that. He has chronic low back pain. He's had multiple steroid injections and 1 episode of nephrolithiasis 8 years ago. And of course, he has a kidney stone now on the left side, and he has seasonal allergies. His grandmother was on peritoneal dialysis due to diabetes. He drinks regularly, drinks alcohol regularly, and smokes marijuana, but no tobacco or illicit drugs. His medications, omeprazole 20 milligrams a day, Flexeril 10 milligrams as needed for muscle spasm and muscle pains, naproxen 500 twice a day, which he has been pretty much taking it. He's on cetirizine for allergies and omega-3 and vitamin C. He doesn't have any allergies, or medication allergies. His exam, his blood pressure is 164/107, heart rate 69, temperature, he's afebrile. He's 209 pounds, 5'8", with a BMI of 30. Actually looks pretty good. He's non-toxic, no distress. His lung, cardiovascular, and abdominal exam are all unremarkable. He doesn't have any lymphadenopathy. He doesn't have any lower extremity edema. Sodium is 142, potassium is 4.8, chloride is 108, bicarb 22, BUN and creatinine are 35 and now 7.1, glucose is 122, total protein of 5.9, albumin of 3.2, calcium is 9.6, total bili 0.3. The rest of his liver numbers are normal. Uric acid is 8.4. His cholesterol panel, his cholesterol is 228, triglycerides 131, HDL 30, LDL 172. His white count is 9, hemoglobin is 10.8 with a platelet count of 219, and his differential is listed at 52% neutrophils, 25% lymphocytes, 13% monocytes, and about 5% eosinophils. By the time of the biopsy, we had some serologies back. His ANA was not negative. His ANCA, as usual, is pending. ANCA takes a few days in our institution. He actually came on a Saturday. His biopsy was done pretty much like Tuesday morning, so a lot of his labs were still pending. His complements were normal. His SPEP was still pending, and his viral serologies, Hep B, Hep C, HIV, and COVID were all negative. His urinalysis was clear, specific gravity of 1006, pH of 6.5, protein 30, glucose normal. Everything else was negative. Microscopy was also unremarkable. His protein in the urine was 83 milligrams per deciliter with a creatinine of 52, so a protein creatinine ratio of 1.6 grams per gram. His albumin was 1.6 milligrams per deciliter, so an albumin creatinine ratio of 31 milligrams per gram. His renal ultrasound showed normal sized kidneys, but increased echogenicity on both sides. And the CT, as I mentioned above, he had a 5 millimeter non-obstructive left stone with post-surgical changes in his sigmoid colon. So since we hydrated him over the weekend, he didn't get better. We weren't really sure why his creatinine jumped from 1 to 7 in 1 year. We went ahead and did a kidney biopsy.
Great. Any questions for Dr. Gashty? Great. Steve?
Did anybody look at his fundus?
Dr. Glassick, we did not.
Okay.
First, you have to find an ophthalmoscope in the hospital. That by itself is a challenge.
Well, I don't know. A black man with a diastolic pressure of 107 and AKI, I probably would want to see what his fundus looked like. Would you, Steve? Would you agree?
No, it's a throwback to a different time. You want to see if he's got some papilledema or something else going on there. That I think is what you might be alluding to, or whether he's got exudates. But yeah, I think that could be helpful.
Great. Steve, without ophthalmologic examination, can you discuss this case?
Sure. He's got acute renal failure. I would think. I don't think it's as kind of has been alluded here. It's hard to believe, given the history, that this is more chronic. But the things that suggest it might be is the fact that he's got a mild anemia and that he does have echogenic kidneys. So if he's had poorly controlled hypertension for the last year and say he's ApoL1 positive, this would be the second hit. I guess we could find small vessel disease or hypertensive renal disease. I mean, that'd be one thing I think we could think about, and that would give you a relatively bland urine. He has no, blood by dipstick. He's minimal protein. That's one. I think two is the issue that kind of comes up here is he's passed 1 stone. Maybe he passed 2. I mean, he still has one on the right side or left side, and he had right flank pain. And then there's bilateral stranding that they see on the imaging, making you wonder whether there's back pressure that caused increase in lymphatic fluid. Maybe he had bilateral stones past 1. And what we're seeing here is some acute renal failure from that just hasn't resolved. I would have thought, unless this had been going on for a while, I would have thought his creatinine might have come down a little faster with just hydration. I guess the other thing would be ATN from NSAIDs, he doesn't really have much in the way of proteinuria, so I don't think he's got minimal change disease. You could get interstitial nephritis from the NSAIDs, but he doesn't really have much in the way of pyuria. And so, if for whatever reason with the bilateral stones that he was for whatever reason might be a little volume contracted, that plus the NSAIDs could cause him to have some ATN. And as just was popped up in the chat, you've got this discrepancy between the protein creatinine ratio and albumin. You've got a protein creatinine ratio of 1.6 and albumin of 31. And so, you kind of wonder whether that's, is this all, low molecular weight proteins because of tubular interstitial disease that's chronic in nature for whatever reason, and it's leading to a beta-2 microglobulin. So low molecular weight proteinuria, or is this an indication of a bigger problem in a guy that's 58 who now comes in with relatively acute renal failure? And we just don't have a good answer for it. And we're looking for, as one of the chat people had brought up, a paraproteinemia. I mean, it's one thing to think about. Like I said, this could be low molecular weight proteinuria from chronic interstitial disease from whatever reason. Again, maybe hypertension. I mean, you have to think about, I guess, paraproteinemia in somebody who has unexplained acute renal failure. And so I would think at some point, urine serum immunofixation might be helpful. You get lysozymuria with myelomonocytic leukemia, but I don't know that that gives you acute renal failure per se, unless you have infiltration.
Actually, it does.
Pardon?
Yeah, actually, it does. It's associated with acute renal failure.
Myelomonocytic leukemia.
Lysozymuria.
Is it? Okay.
Yeah, I only know that because I saw a recent case report in AJKD. I've never seen the case. It's on my bucket list.
Yeah, interesting. It's one of the other causes of, I guess, overflow proteinuria, if you will, but I didn't realize that. You'll have to tell us what the mechanism is. I mean, well, anyway, so I mean, at the end of the day, obviously the biopsy is going to be extremely helpful here for sure. If it's a paraprotein associated renal process, we back into these diagnoses all the time by way of the biopsies. So, I mean, that's an interesting thought, but I have to admit, the NSAID history with the stones, you kind of wonder whether this is just ATN.
So, Casey, in the chat, somebody brought up the vitamin C issue, and certainly, oxalosis, or they said oxalic acid stones, but there's been cases of AKI from megadoses of vitamin C. Do we know, does he take a lot of it, or we don't know?
He's just taking 100 milligrams a day.
Okay, that's not much, but that's definitely been, described in kind of a surprise biopsy in people who take health doses of vitamin C. They get hyperoxaluria and acute crystalline deposition with AKI. I guess Dr. Carl and Dr. Reen both mentioned the paraproteinemia, and kind of independent lesions want to be a TMA, which, something I don't always think about as part of that pathophysiology related renal diseases of monoclonal related. And the other was just, some kind of gas nephropathy, et cetera. Those are all interesting points. Realize this is Dr. Gashti, and Dr. Gashti's 9 times out of 10 when he does a biopsy, this is some interstitial nephritis, but he's shaking his head. But it's true, Casey. You are Dr. Interstitial Nephritis, whether you like it or not. Bill, what do you think's going on?
Yeah, I think if I saw this patient in the hospital like Casey did, I'd put, ATN really, really high up there. And I think it still should be, ATN from NSAIDs, and he's kind of sick. And I think that's most likely interstitial nephritis. He's on the omeprazole, or NSAIDs can do it too. But I like the idea of the, since this is more of a conference right now and it's a little bit more gamesmanship, I do like the idea of a monoclonal protein. I mean, if we look at it, he's got chronic low back pain. He's got the albumin to protein creatinine discrepancy. He's anemic. His calcium's 9.6. And if you're really having that bad a renal failure and your phos is high, maybe your calcium should actually be 7. So this is a relative hypercalcemia for his degree of renal insufficiency. So I like the idea, and I definitely would make sure that there's an SPEP and a UPEP there. And if it is AKI with it, I would probably put CAS nephropathy up there pretty high. But I think that's more gamesmanship and conferencemanship or personship. And I think more likely it's going to be ATN.
We call that billsmanship.
Exactly.
So what about PPI? And
yeah, the omeprazole can do interstitial nephritis. It seems pretty fast, but it's definitely could be there. We think about sterile pyuria and a peripheral eosinophilia and those kind of things, but you don't have to have any of those to have the interstitial nephritis from the PPI. And if it's an NSAID interstitial nephritis, it's a little bit more indolent, as far as a little bit more fibrotic and scarring, and not such big on the eosinophils.
Also in the chat, was brought up this fact of synthetic marijuanas are now associated with AKI. Casey, we don't know if he's got regular, street pot or whatever.
No, I didn't really delve into it. I know he just smokes marijuana. I
Yeah.
didn't ask the subtype.
And Dr. Reen says cannabinoids can also cause TMA. I wasn't aware of that. I don't know if that's a synthetic or not. Maybe you can put a note in the chat or some kind of reference to that. I mean, certainly, AKI with a pretty benign urine, you can think about small vessel conditions like a TMA. We hear about this all the time on the floor when people talk about paraproteinemias, and they always look at the gamma gap, and this is pretty slim. I mean, we don't necessarily have to have a high total protein, but it's pretty unimpressive here. Do you think that's important, Bill?
Yeah, I actually looked at that when I was kind of seeing how likely it is that that he may have that. And no, I mean that doesn't exclude it for sure. But yeah, you'd classically like to see a little bit higher of a total protein there.
Wouldn't that be primarily if you had a heavy chain involved where you've got a high gamma globulin level? I mean, as opposed to just light chain proteinuria?
Yeah, that's true. But yeah, absolutely. But yes, Steve, it would. I don't know what to say, but yeah, you're right. I just look at these things sometimes, and what always comes up is hypercalcemia and high total protein or gamma. The difference between the total protein and the albumin being the gamma gap. And I don't know that they're that useful, but I guess Bill's making a point that the adjusted the calcium's even higher than you would think. That would never be a flag to me, but it may still be like Bill says. You look for things here. He's got 4.5% eosinophils. I think that's kind of interesting and might sway me a little bit more towards an interstitial nephritis of some type.
With no pyuria.
Well, he's got an allergic. I mean, I think that's abnormal, and he's got somewhat of an allergic reaction. Yeah, I mean, he has nothing in his urine, so that doesn't. He has nothing. So I don't know what to make of that. And as well as I do, our urinalyses that come from the lab aren't the best. So, but be that as it may, anybody, Dick, what do you think's going on?
Well, I hear the hoofs of a zebra in this case. So I'll contribute something out from left field. This is new onset severe hypertension with AKI. And anytime I see that, I think scleroderma, renal crisis. And there are cases in which there has been no physical evidence of scleroderma, only renal disease. And I'm thinking maybe scleroderma without scleroderma with a crisis. That would explain a lot of things in this case. The one thing it wouldn't explain is the right flank pain, which I don't know, nobody knows where the origin of that is, and the extreme polyuria. Look at the specific gravity of his urine. I mean, this makes interpretation of the urine a little bit less useful because he's got extreme polyuria. We don't see anywhere here what his daily 24-hour urine is. We don't have a urinary osmolality, but I'm curious to know, does he have acute nephrogenic DI? Has he infarcted one kidney and developed polyuria from acute loss of function in one kidney? But I'll just toss that out as a zebra.
Yeah, it's a good point because, we've had a few of those. I think Bill had one, and, unexplained renal failure, and really there were no peripheral stigmata. And we do a biopsy and we see signs of malignant hypertension and a little bit more in the vessels to suggest and go back and serologically, we find that this patient does have some very, very subtle evidence of scleroderma. Bill, you had a patient, right?
I did. And it's also interesting that you bring that up with the dilute urine. I mean, if this was something like sarcoid, you could have central DI in sarcoid from like hypothalamic involvement, and so that could be a possibility too. We got an interstitial kind of looking pattern in a black gentleman, and he may have a DI as well.
Well, can't hypercalcemia also lead to a nephrogenic DI, right?
Mm-hmm.
Yep. So yeah, that's interesting. I love zebras. And like that, I mean, that's clearly, that was Bill's point. It's the problem. You think, you have to think out of the box because this is being presented as it is. Dr. Rubin, what do you think's going on? Mara, are you still with us? He might have stepped out. His mic's on. Well, I think then if with that, I think it's time to take a poll and let's see what.
Roger?
Yes.
Before doing a biopsy, how many of you would have done some kind of further imaging of the kidneys? Say a DMSA. I'm not suggesting a renal angiogram, but some kind of relatively non-invasive imaging other than ultrasound that might give you some idea of function and appearance of the two kidneys.
I don't think it's a bad idea. I wouldn't have thought about it. I wouldn't have thought of it. It's not
Okay.
something that I commonly think about. Anybody else?
I mean, the only problem in him is he's still got a stone in the right kidney, or I keep getting it wrong, in the left kidney, in the left ureter. So he's still obstructed on that side. I don't know if it's going to be that accurate.
I think we have we did have a CT at least that showed the stranding, and there was at least nothing obvious like a major infarct. Let's run a poll. Let's see what the audience thinks. We've got 5 potential diagnoses here. What will the pathology show? We've got 1 ATN, 2 AIN. So we've got ATN from nonsteroidals, AIN from nonsteroidals, or the PPI oxalosis or diffuse oxalate deposition from the vitamin C. We've got sarcoidosis was brought up towards the end, and we've got a paraprotein related renal disease, which was discussed. One of the more popular because of Billsmanship, I'm going to call it from now on. Whittiermanship. I like that, Bill.
For once, ANCA was pending, but I don't think that really plays into a role here. But it just
Yeah.
We were waiting for that, but I don't think, based on stuff in terms of the urine, I don't think that's even on our differential.
Yeah, I mean, the only way this would be a vasculitis, I suppose, would be a large vessel preglomerular vasculitis, which could have been, with the hypertension. Actually, is not a totally unreasonable diagnosis. It didn't make the poll, so maybe that means something. I don't know. We try to make these polls pretty blindly, though.
Yeah, maybe the right answer is not on the poll.
Yeah, maybe.
To be
Very well.
to be seen. I don't know. Results are out.
Okay, we've got
Whoa.
a whole smattering of answers here. 13% said ATN, 28% said AIN, 15% said oxalosis, 17% said sarcoidosis, and the highest is actually a paraprotein related renal disease. Interesting. I think it's time to spin the wheel and see what kind of zebra we have. When people say zebra, we should always mention Fabry disease, but another bad joke. So I think I better quit. You just shut up. Bill laughed, but he's got Fabry patients. So
Right.
He's not going to read his own case. Wow. It's me. All right.
Should we have the disclaimer that you're colorblind and so we shouldn't judge you on your stain?
I only do that when I get things wrong. So
Okay.
actually, I see perfectly well, but if I can advance now.
There you go.
All right, so we've got two cores here with it looks like a lot. It doesn't look very normal here. It looks like a lot of disease. There's not much else to say, but a fair amount of tubular separation and some blue staining material. We'll get a better idea, but it doesn't look like this is really something that's very acute. I think it's been going on a while. David, you're on still, right?
Yep.
Okay, David's gonna have to leave a little early, but we'll see. So very abnormal looking. I don't want to say more than that right now. You know, we're looking for chronicity, interstitial nephritis, nothing, maybe ATN, and we're looking for signs of a paraproteinemia. And I do this to myself all the time to help me kind of read it in the context of the case. So here we've got I think this is a PAS.
Yeah.
Oh, 50-50. So we've got a PAS of single glomerulus here. Here's the vascular pole. You guys see my arrow?
Yeah, we see it.
Okay, there's a vascular pole. Looks a little thick in here, but it's hard to say. And there's some tubules here that a little bit of peritubular fibrosis. Here's a cast here. Thinking about cast nephropathy, I wouldn't make anything of a single cast right now. The glomerulus looks okay. There's a little bit of mild mesangial increase, but certainly no segmental lesions, no necrosis. I don't see a lot of PS weak materials suggesting an amyloid or something. Right now, I'm not getting a whole lot. I don't know if there's protein reabsorption here or not. I'm saying no, now that I look at it a little closer. Maybe some ATN down here. And not a lot of interstitial nephritis to speak of. And this glomerulus, here's the proximal tubule takeoff here. So you got the vascular pole and the proximal tubule takeoff. So I don't see a lot here so far.
Yeah, I agree with everything you said.
We jump into a Jones, I guess. And here, glomerulus fills the capillary, fills the Bowman space. I think this is, again, the takeoff of the proximal tubule up here. Looking for holes, splits. With amyloid, sometimes you can see some what look like spikes. I don't see anything there. I don't see any holes. I don't see any duplications. I think this is just blood in the tubules here. I don't see any much of anything.
Yeah, basement membranes look smooth, no spikes or holes.
Getting back, thinking about hypertension, it doesn't seem like it's an ischemic or shrunken glomerulus. I didn't look at any vessels yet, but thinking about scleroderma and onion skinning, that was also in the differential. Sarcoid was in the differential. We should see maybe more interstitial nephritis. We'll probably get some more pictures. Maybe a granule if that's because I kind of get the sense there's some holes here in the mesangium, but I don't know. Is that real, David?
Well, I mean, that's the way the mesangium always looks on the silver stain.
Got it. There you go. That's why we have David here.
Yeah.
The glomerular sarcoid would be membranous, but we weren't really suspicious of that here.
So here we've got now, we're going backwards. So here we've got a core again with a fair amount of interstitial nephritis here. Tubules are pretty widely separated and a fair amount of cells. At this power, I can't really tell you what they are.
Yeah, and it is kind of patchy because over on the right, you could see less infiltrate there. Yeah, and dense right in the middle, as you pointed out. Yeah, less on the left. Yeah,
and no granuloma, at least, as far as I can tell. But so there is some interstitial nephritis. So I think we have some interstitial nephritis, probably some ATN. And here's, again, showing some interstitial nephritis. And here's a cast. Again, I don't know. Going back to our cast nephropathy, it's not fractured. I'm not going to make anything else. This is a cast, not a sclerotic glomerulus, right?
Right.
Okay, yeah, so it's a cast, but it's not at least fractured. I don't know. We'll have to see more. And these cells here, I don't know. They're lymphocytes, right? I don't see maybe an occasional poly or plasma cell. I don't know, but they're just mostly lymphocytes.
Yep.
And if there's EOs, I'm not sure I'd be able to tell, but I don't. Sometimes when they're pointed out, I can see, but I don't see I don't see any EOs.
No, there are none in this field. Yeah, predominantly lymphocytic with an occasional neutrophil.
So now we're getting more and more casts, which is making me really wonder. And this one's kind of broken, and this one looks a little broken here. And then, it's hard to ignore them in the context of our differential diagnosis of possibility of cast nephropathy. I guess we'll have to see if these light up on IF, and if they're light chain restricted. Other than that, it's pretty much not a bad looking interstitium, a little bit separated.
Yeah, I mean, that one in the middle definitely looks fractured. You have that kind of crack right through the middle. Yeah.
Well, now it's more and more, so it's kind of hard to ignore this. Sometimes we see what's called thyroidization, where you see dilated tubules. It looks like the thyroid, and that in chronic renal disease we'll see that. But go back here. But I don't know. When they're fractured, it's because they're felt to be very stiff and rigid, and I don't know that the lack of fractures here is pointing me away, but it sure, given the context of this disease, sure makes me think about cast nephropathy. I just have to, I don't know what else to say.
Yeah, even that one, look up at 10 o'clock, Roger. Yeah, those look even kind of clumpy, thick.
Yeah.
So David, in cast nephropathy, they always talk about this giant cell reaction around the tubules as well. And it's not just, like thyroidization wouldn't have that. Do you see that kind of inflammatory process?
No, I didn't see a good giant cell reaction.
And a PAS of the interstitium, show some atrophic tubules here. I don't know what else. Maybe this is some
Yeah, and then
here.
some ATN in the middle. Yeah.
Yeah, some ATN
Sloughing,
here.
lots of brush border.
Yeah. And so, wow, this is interesting. So this is our kappa stain, and it's highly positive in the glomerulus and the tubules, which is, I think, a little unusual for cast nephropathy. If this were when I see it in the tubules like this, I think about light chain deposition disease, but we didn't see the typical nodular glomerular sclerosis that's often associated with that. And I don't know how much you need that or not, but this is certainly.
No, over the years, we've seen several cases where we don't have the typical nodular glomerulosclerosis. I remember Bill had a case or two like that.
Actually, and in the series from Columbia, it's the same thing. If you had cast nephropathy coexisting with light chain deposition disease, they rarely had the nodular disease, and they were rarely that proteinuria.
Interesting. I mean, that's kind of where, Steve might have just given us the diagnosis, because we'll see if the casts light up. Yeah. But this is clearly abnormal. I also want to see if lambda is negative. I'm sorry.
I read your mind.
I go, you couldn't have made it more positive. You couldn't have a better negative and more light chain restriction than that. So we've got this kappa in the glomerulus and the tubules suggesting some kind of light chain deposition. And I don't know. Do we have the casts on?
There you go.
You're
answering your own question.
I swear this is not staged. I know David would order it. So here we've got the cast also lighting up with kappa. So we have light chain restriction in the cast, light restriction in the tubules, and clearly negative with lambda. Not even a suggestion, except this little fluke here. So that's really remarkable.
So the myeloma casts were only focal on the fluorescence, but this is the same area on the two different stains. You can see that one cast is positive on the left for kappa, same area, same cast is negative on the right.
There's been a number of things in the chat. If anybody thinks there's important, please pipe in. I'm too busy looking at this and trying not to make a fool of myself. So here's an EM. We've got mesangial here. We've got the capillary loop here. We've got the blood space here and the urinary space here. The photocytes don't really look bad. They look pretty good, to be honest. Maybe some focal effacement here and there. The mesangium doesn't look expanded. I don't see any electron dense deposits. Sometimes
so Roger, there are some vague deposits.
Well, I was just going to get like here.
Yeah, right in there.
Yeah. So sometimes with these deposition disease, you'll see some deposits, and they can kind of have a fluffy appearance, and but it's pretty subtle to me, and nothing to suggest. Oh, we had a Congo Reds negative, right?
Yeah, I was negative. There's no amyloid.
That's important too. And here's some more deposits, I think, down here. Go probably higher power here. Well, there's a big arrow that's showing, that's obviously pointing at something here.
It's pointing at,
Yeah, so and then, you know, light chain deposition disease, or monoclonal globulin deposition disease, you should see these, you know, powdery type deposits on the subendothelial side.
Yeah, so that was what I said fluffy. I was trying, that's the powdery is really
Yeah.
is the term. And I'm going to take your word for it here because I'm not good enough to recognize that, but I'm glad you pointed it out because that is kind of the lesion that's described. The basement membrane is pretty normal here, but
Yeah, and then as you
Yes.
traced around to the left, yeah, they're there. They're just not well formed. Yeah, there they are. Yeah.
yeah, I wouldn't have been able to recognize that. But I'm really glad you pointed that out because that is exactly what's described. We've seen them where they're much more obvious. They're quite there. They've got this feathery kind of powdery look or whatever. The podocytes look good though. They look pretty good. At least over here. Here's a little more abnormal, but this may be heading into the mesangium, whatever. So interesting. And I think that's the same thing, just the same one on lower power. Podocytes don't look as good here. And we can see some of these deposits here, mostly kind of in the mesangium. Here it's kind of subendothelial, kind of close, but interesting. So I guess our diagnosis is cast nephropathy with light chain deposition disease, kappa restricted, and wow.
gamesmanship.
Gamesmanship, exactly. Billsmanship.
Along with ATN and that chronic interstitial nephritis.
So, we typically think of these things as the remark. I was talking to residents today about the vast spectrum of paraproteinemia related renal lesions, which I'm sure we'll talk more about. But the amazing thing to me is that how different paraproteins can have such a wide array of pathologic patterns, and I don't think we know why they do this. And I know that I tend to think of this, you have one or the other. You've got amyloid, you've got cast nephropathy, you've got light chain deposition disease, you've got one of these lesions. But as Steve brought up, it's not unusual to see them together. I just don't know how often, and I don't know that we've seen them that very often together.
It's a third of the time in the Columbia Presbyterian literature, at least in their experience, the Vivette Degotti's paper. And they don't usually have nodular glomerulopathy with them. Anyway, Casey's probably, I'm not going to take away from his, but it's about a third of the time.
That's great. Yeah, and I don't know, that's, I hate you overly use your experience, but that's really important information. I think this is a really, really good example of that. And I think as David pointed out, or Steve pointed out, that the lack of the nodules is not unusual, because that's what, I always teach our fellows, look for nodules, look for nodules. Look, it's a diabetic who's not diabetic. It's diabetic glomerular sclerosis, not diabetic, not a smoker, and then the immunofluorescence will give you your diagnosis. Because the DD of nodular is interesting, but this was anodular light chain deposition disease. Anybody have any other thoughts before I hand it over to Casey? Casey,
Roger?
yeah,
Roger? In light of what we've just seen in the pathology, is it possible that this patient also has nephrogenic diabetes insipidus?
I
Did
think
we
it is.
look- I mean, the extreme polyuria in association with this kind of diffuse tubular involvement without glomerular involvement, definitely of a light chain deposition disease variety, I believe have been seen in patients with this disease. So it would be very interesting to know what his urinary osmolality was and whether he responded to desmopressin.
Yeah, and yeah, frequent urination, exactly, almost hourly. Yeah, that's where that comes from. Yeah.
I mean,
Casey, do we even know that he was polyuric, or was it just frequency?
No, he is polyuric. He urinates quite a bit, and he's hourly use of bathroom. So he's both frequency and polyuria.
Yeah, that's a really good point. That would have been a fun thing to do. Overnight restrict him, see what kind of urinary osmolarity he can generate on his own, and then just give him some DDAVP and check it. It's really easy to do. At least in the hospital, it's very easy to do. Or you could even have him come in and just drop off a urine and check urinary osmolarity, check a serum sodium, fluid restrict him overnight. And
Well, Roger, the only point is if we knew that he had nephrogenic DI, before the biopsy was done, that would have greatly enhanced the likelihood of a paraprotein disease and would have greatly diminished a lot of other diseases. It probably would have increased Sjogren's syndrome as well. But I'm just saying that maybe we had some clues to this disease before the biopsy was done.
Yeah, and absolutely. I mean, we don't not leave things out that are relevant, but and we didn't leave anything out here. Casey, was this high on your list before you biopsied the patient?
It wasn't. I mean, this was one of the situations where we always, ask for a biopsy and it doesn't happen for like 4 or 5 days and everything comes back and we have a pretty good idea of where we are with our differential. And this happened to be one of those cases where we actually had a biopsy result back before we even had our SPEP back. So it's kind of rare that happens, but this was one of them. And I'm glad at the end of the day, we have a biopsy. Obviously, we needed to prove, cast nephropathy as a myeloma defining lesion and kind of pass them off to hematology. But that, this is just how the sequence of events worked out in this case.
Hey, Mario, if you're on, what would be your next step in this case?
Well, I think that we'd like to get the pertinent dysproteinemia workup. I noticed that Casey did not give us the SPEP yet, followed by immunofixation, followed by a free light chain assay, and of course the bone marrow.
Yeah, I guess it's a good point. We don't even know. We don't even know if there's a circulating paraprotein. We often find renal disease without a circulating paraprotein, a monoclonal gammopathy of renal significance, when we don't know it's it's circulating or find a bone marrow evidence of it. I don't know about the other way around. Casey, what'd you find?
All right, Prevere, can I have the slides in control?
Go ahead.
Okay, so here's a follow-up. So as Dr. Rubin asked, SPEP and immunofixation. So we have a monoclonal free kappa light chain in the serum, and the concentration was 1,345 milligrams per deciliter. And we found the same free kappa light chain in the urine, 80% was in the beta fraction. The bone marrow biopsy was done and was consistent with 45% plasma cells. The skeletal survey did not show any lytic bone lesions, so the low back pain could, at the end of the day, still be just a garden variety of low back pain and not related particular to this lesion. Cardiac evaluation with an echo showed just a mild LVH, but the patient had a normal systolic and diastolic function. And it will kind of talk a little bit about management. But so, when we found out that the patient had cast nephropathy, that by itself puts the patient into the category of myeloma. And so we called hematology. And the first thing they asked us was, yes, we're going to definitely start chemotherapy, but could you start plasmapheresis or plasma exchange? And, I go into a little bit of data about, whether that's useful or not in this particular setting. But so the patient did receive 5 sessions of plasma exchange, followed by bortezomib-based chemotherapy with cyclophosphamide, bortezomib, and dexamethasone. And thus far, which is about a month out, he's had a fair light chain response to a point where his light chains have gone down by 300 milligrams. It's not great. And his serum creatinine, unfortunately, is still slowly inching up despite giving him fluids and stopping the NSAIDs and all the other stuff. He's getting plenty of dexamethasone. So his creatinine remains at 8, and he's unfortunately approaching dialysis. He's not on dialysis yet, but he's getting there. So, Roger, you mentioned something about how we don't know how some of these proteins cause various lesions. We have some clues. What I kind of found interesting is that it's really not about the type of clone. It's about the actual structure and the physiochemical characteristic of the protein that decides what kind of lesion it's gonna end up being. So, for example, if some of these light chains, for example, if they're positively charged or they're glycosylated, that increases their affinity for the basement membrane. So you may get more monoclonal immunoglobulin deposition disease, MIDD, which light chain would be a subcategory of that. There's also changes as far as mutations. There's a light chain with, these peculiar, they call it, highly variable N-terminal mutations. They're called VL mutations. And that makes these light chains resistant to proteolysis. So when they get picked up by the proximal tubules, they cannot get broken down as a protein. So they get essentially precipitated inside of the cytoplasm of the proximal tubule. And that's called a light chain proximal tubulopathy. They in fact sort of crystallize. So there is definitely some understanding of the characteristic of the light chains and sometimes the heavy chains in understanding what the lesion is. And of course, we all know that the misfolding of the light chains leading to a variety of different fibrils and tubules can lead to amyloid and such. I find this very useful, this graph, in the sense that it kind of tells us where the lesion of paraprotein-related disease is. And these are under the category of MGRS. I have to say that this patient does not have MGRS. This patient actually has myeloma because of the CAS nephropathy. If the CAS nephropathy was not present, the light chain deposition disease by itself without anything else, I mean, we didn't know the bone marrow at the time. We now have a bone marrow. So this patient does have multiple myeloma, full-blown, no questions asked. But we do have these lesions that can be caused by paraproteins, and it could involve anything from the vasculature, both from intraluminal occlusion causing crystal deposition and crystalloglobulinemia, which can actually lead to digital necrosis and loss of appendages and fingers and toes and such, cryoglobulinemia, as well as deposition of amyloid fibrils, so vascular amyloid, as well as the deposition of the light chains within the myocytes of the basement membrane, as well as the basement membrane of the tubules, as well as the mesangium and glomerular basement membrane. So the light chain deposition disease is one of the light chain lesions that involves the glomerulus, the vasculature, and the tubules. The amyloid also can involve the vasculature and the tubules as well. So one of the other questions that was brought up, and Dr. Corbett answered it, the Columbia group did have published data on, what are the percentage of patients who have or CAS nephropathy plus other lesions. And there are other series too. This is one of the series where pure myeloma CAS nephropathy was seen in about 50% of the patients. But so most patients who have a paraprotein and they have some kind of a kidney abnormality, if you biopsy them, about half of them have something that has nothing to do with the paraprotein, and half of them do have something related to the paraprotein. So if you take the ones that do have paraprotein-related kidney disease, the breakdown is about 50 to 60% of those patients. And of course, it depends on the presentation and patient selection. If they have renal failure, they're more likely to have a CAS nephropathy. And but there is also CAS nephropathy concurrent with amyloidosis, concurrent with light chain deposition disease. So the two that can definitely coexist, as Dr. Corbett mentioned. The next question we had was, when hematology asked us about plasmapheresis, we were sort of not really sure what to say. We were like, okay, well, the old data for sure from randomized trial by Dr. Clark from Canada showed that there wasn't really much of a difference. And that was slightly older data, meaning that it wasn't in the era of bortezomib-based therapy. We didn't have the current clonal-directed medications that we do now. So is there a difference nowadays with the current chemo? Well, you could argue that current chemo is actually better. It reduces your light chains even faster. So the role of plasmapheresis should actually be even less. Dr. Hutchinson from England has had a couple of randomized trials, the MYRI trial and the ULI trial, where they actually compare patients with CAS nephropathy who are on dialysis and whether they're receiving conventional hemodialysis versus his high cutoff filter, where it actually removes light chains. And unfortunately, both of those trials showed that the primary endpoint was no different no matter what you use. And so unfortunately, you know, both of those studies were underpowered to show what could have been potentially clinically significant. We don't really know. So the data is still rather weak and not very sort of convincing. But I found this paper from Mayo, which looked at patients with very similar to our patient, 14 patients with myeloma. 7 of them had fresh diagnosis. The other 7 had relapsed myeloma. And the biopsy showed CAS nephropathy, and they had to have a pretty high free light chains in their serum, so over 200. Our patient had about 1,400, so definitely fits the criteria here. These patients all received plasma exchange plus bortezomib within 7 days of diagnosis. And the median number of treatments were about 8 plasmapheresis treatments. 6 of these patients had complete remission, meaning that they had normalization of their serum creatinine, and you can kind of see their GFR were all less than 20 at baseline, and their GFR, most of them actually did improve with the exception of 2. So half of these patients actually had complete remission. 6 of these patients had partial remission, which was defined in more than 50% reduction in creatinine from the peak, or that the fact that they come off of dialysis. So if you combine these two, 86% of these patients had at least a partial or a better remission at 6 months. If you compare that to historical control, I know that's not a good thing to do because this is not a randomized trial. If you look at patients who are on dialysis and they receive bortezomib-based therapy at 6 months, half of them are off of dialysis, the other half are not. And there's a high mortality rate with this disease. So, and even if you break down these patients, 7 of these new patients had, 7 of the patients were newly diagnosed myeloma patients, and 57% had complete remission, 29% partial. So again, whether this is new diagnosis or relapse, you still have a pretty high chance of having at least a partial remission. So the conclusion by Dr. Long was that the plasma exchange plus bortezomib is remarkably effective in reversing acute renal failure, presumably due to CAS nephropathy. And so, again, not excellent data, not randomized trial, but at least we did it in our case. Our patient is still not, the creatinine is not getting better, but the light chains have sort of improved. So that's kind of where we are. He's, I've been talking to him about dialysis. He's, his grandma was on PD, so he's not really happy about it. So we'll see what happens with him, but he's about a month into it. So that's pretty much what I have on follow-up.
That's
Casey,
great.
was this plasmapheresis? I may have missed it. Was this a special type of filter? Was it just a routine?
This is regular plasma exchange. The ULI trial and the MIRI trial, those were the high cutoff filters. Those were the ones that do 5 to 8 hours daily of dialysis with a porous filter that removes the light chains. And they all showed that there was reduction in light chain, more so in the high cutoff group than in the conventional dialysis group. But that early reduction in light chain did not translate into long-term renal benefit in the sense of patients coming off dialysis more so. But there were about 40 patients in each group. So that was really the big downside of those studies was it was really just underpowered.
What's interesting to me about this, and you alluded to this, and I think Roger brought it up as well. I mean, you very, very nicely explained, how some things form CAS, others get into the basement membrane and cause light chain disease, and then others form this tertiary structure called amyloid. But, the issue used to be was if you had one, that's all you had, you didn't have the other. And what's interesting to me about this is you have 2 things coexisting at the same time. So there's clearly something different about the light chains that are causing the CAS nephropathy here and the light chains that are causing the light chain deposition disease, if you will. And so I wonder whether or not we've got 2 different clones of kappa chain that are being produced here that are allowing it to have these 2 things occurring at the same time that normally don't.
So we know that this patient does not have 2 clones because they stain the bone marrow for the type of clone. And if there are 2 clones, there are reported cases of patients who actually have 2 separate clones. They actually have concurrent CLL and let's say Waldenstrom's, or they have CLL and myeloma. So they identify the clones in the bone marrow. This patient, based
why
on
is
bone
it
marrow
though that in
testing,
this
does not.
patient
But
you have
Casey,
both things going on, CAS being formed and this light chain deposition disease with the granular deposits in the basement membrane? I mean, something then maybe I don't know how, if there's something more, like you say, if you're saying the light chain has a certain property that predisposes it, then there must be something else happening here that then allows that same light chain that would make, that would cause light chain deposition disease to now precipitate into the tubules and cause cas nephropathy.
Could have been the NSAIDs. I mean, he could have had light chain and he took a bunch of NSAIDs and he has enough light chains in the tubules that enough volume contraction inside the tubule caused it. I'm not really sure what the trigger point was.
But that explains why people get cas nephropathy anyway. Furosemide, contrast, NSAIDs, but it doesn't explain why there's both cas nephropathy and light chain disease.
Sure.
And the same thing in amyloid. Now, he used to talk about the fact that you didn't see these coexisting with amyloid, and as you point out, in this other paper in 2021, the first paper that I saw from Lynn was just looking at light chain disease. And that's where a third of them had coexisting casts. That was in 2001 in Jason. But I always found that fascinating how these things can coexist when historically we thought they wouldn't.
But I'm with you, Steve, on this because this patient has the uncommon form of multiple myeloma called light chain myeloma. So clonal biclonal disease doesn't apply in this patient because there's no heavy chain compound. And this patient with light chain myeloma characteristically represents a great diagnostic challenge because serum protein electrophoresis will not detect it. It's a very poor screening test for the detection of light chain multiple myeloma. You have to do immunofixation and serum-free light chains to detect that. So if you have a patient with acute renal failure in whom you're suspecting light chain multiple myeloma, do not do a serum protein electrophoresis as your initial screening test. It's useless. You need to do free light chain and immunofixation, which this case, I think, really beautifully illustrates.
Well, the kappa lambda, the free light chain analysis, the nephelometric assay was just so much more sensitive, as you allude to, kind of did away with the whole idea of the I forget what was called, where they wouldn't pick up the light chains at all because the assay, even by immunofixation, wasn't sensitive enough.
Non-secretory.
Non-secretory. Thanks, Mario. Yeah, I mean, that category almost is non-existent now. And this, I mean, it is impressive, Casey. I mean, oh my God, that ratio was off the charts.
Yeah, I've never seen
You
anything
know
that high.
what? That brings me back to Robert Kyle. 2 points about Robert Kyle. One, very early on, and this is where Dick just confused me, he spoke about that 75% of cases of myeloma had the immunoglobulin detected. About 24% had light chain, and 1% were non-secretory, which when the nephelometric assay for light chains came about, was a non-issue. So I don't know, when Dick says that light chain myeloma is uncommon, according to Kyle, was not that uncommon, but so be it. The other issue about Robert Kyle is way before Nelson Long got on board with the Mayo Clinic team, he did a study that they published in Mayo Clinic Proceedings about the role of pheresis in myeloma, and they said it's useless. So now we say, well, it may be helpful, but surprisingly, the paper of Nelson Long is only 14 patients. They see tons and tons of cases. How come they only look at 14? I mean, I don't know. I still take it with a grain of salt, whether or not pheresis is useful. I mean, certainly I wonder about infection in the setting of pheresis in myeloma.
I think that's a good point. I think we always have to be careful that just because something has not been shown to be effective doesn't mean it's not effective. And I don't know that the definitive study's been done. And, you did have a significant reduction in the light chain. And the fact that the creatinine didn't get better doesn't mean much to me. Yet I've seen patients come off dialysis from cas nephropathy. I had a patient just after my fellowship, he came off dialysis three months later. So I think it's one of those conditions that you can actually have quite delayed recovery. So I'm not ready to give up on this guy. by any means. Not that anyone's giving up, but I wouldn't be
but-
surprised.
It may happen, but and it's not that you give up on a young guy, but the reality of it is that if you look at the Lynn paper, I mean, these patients, 90% of them presented with acute renal failure, and rarely did they ever come off. I mean, it doesn't mean that a few don't, but the rule of thumb is that they usually won't. And I think the other rule of thumb is when the two coexist, the disease that really defines the course is the cast nephropathy, not the light chain deposition disease. I think the interesting thing here as well, and then I'll shut up, but you had light chains in the glomerulus as well. You just didn't have the nodular glomerular disease. I mean, the basement membranes of the glomerulus lit up like a Christmas tree as well. And I find it interesting that there was little, they essentially had no albuminuria. There was, the albumin was 30 milligrams. And so unlike the nodular, which, presents like diabetic nephropathy and a non-diabetic where they do have fairly significant proteinuria, this person, despite having basement membranes that were clearly affected by light chains depositing, had minimal proteinuria at all.
Yeah.
Casey, I have a question.
Yes.
Did your patient have bone lesions?
No lytic bone lesions.
So I'm glad that you stated the difference between MGRS and myeloma, and you said this is myeloma.
It is.
It fulfilled the CRA criteria, not quite the B criteria of CRAB in myeloma. How was the B looked for, the bone lesions?
Skeletal survey.
Okay, so that has been replaced by MRI nowadays, hasn't it?
Yeah, so they say that if you have more than one lesion in an MRI, that fulfills that criteria. But I think that they probably didn't go any further with him because of the biopsy plus the bone marrow, made the diagnosis for him, and that wouldn't probably change the management.
Yeah, I was just looking for, mainly for the fellows, the CRAB criteria that will nail it.
I mean, this nomenclature gets confusing for me, to be honest with you, because I think somehow, and you can tell me if I'm wrong, you treat them very much the same in many ways. Maybe there are subtle differences, but if Waldenstrom's is not MGRS either, right? I mean, once you've had a defining feature, it no longer becomes MGRS. It's kind of the ones that don't fall into myeloma or CLL or Waldenstrom's, I believe, in the review that Nelson did in the New England Journal of Medicine. Those that don't fall into those categories become part of the MGRS, if you will.
Right.
I think the CRAB criteria is really there because there's, people with smoldering myeloma, and, you need something to really hang your hat on before you start treating.
I mean, once you prove vital end organ damage, then I think that changes it from a undetermined into a significant.
Well, but I'm saying MGRS becomes an end organ that's been involved. It's just
Correct.
that they don't
Correct.
have myeloma.
Yeah, so let's say Waldenstrom, like neuropathy, that's a common neuropathy, cardiomyopathy, all of those things those are considered organ damage. So that defines that disease.
Back when a lot of this Plex stuff was done, it was before bortezomib was available, and we're using melphalan and prednisone and things like that, and those are much slower to act. And it was pointed out in the chat just how quickly bortezomib can work, and that's one of the problems with light chain removal is that, as was pointed out, these drugs work very, very quickly to lower light chain load, and that may be why, if indeed extracorporeal removal of light chains is not going to be found effective. Although I still, I agree with Casey. I probably would have plexed the guy. I think it's the cost is low and the potential yield is maybe there, and
I know this hasn't been shown yet, but you often wonder if they have such bad renal failure, there's not really a great way for the light chains to get out of the body. The kidney is a very good way of having them get out of the body when it's working. And you wonder if there is going to be a randomized controlled trial. It'd be nice to see a group analysis. If it ends up being negative, it'd be nice to see a subgroup analysis in those that had significant renal failure, if there was a benefit there. Because in my mind, the ones that have really bad renal failure like this guy did would have probably, again, this is not evidence-based, but probably the most to gain from pheresis, just from a better way to get it out of the body.
One other thing to keep in mind, that light chain disease, just like amyloid, affects the heart, affects the liver and other organs as well. I mean, this person has two things going on, and Casey nicely showed that the heart looks like it's okay and the liver enzymes are fine. Because for sure, if there was heart failure associated with this, that might change this person's candidacy for a transplant at some point, which is the other issue. Whether he goes on dialysis or not, he's probably not going to recover enough function, to get back to baseline, and it will probably progress one way or another. And then the issue of transplant candidacy comes up, and until his hematologic process is in remission, and in the Mayo Clinic people have shown this beautifully, he won't be a candidate because this will recur very quickly in a transplanted kidney.
Yeah, I just
Yeah,
wanna wrap-
along those lines, I think that the best data comes from Mayo Clinic and BU, and I think the Cleveland Clinic, where a combined bone marrow kidney transplant is the way to go in myeloma. I mean, short of that, it comes right back.
Yeah, I want to wrap up with one point. Dr. Glassick had said if we would have thought about maybe working him up for nephrogenic DI, would have pointed us a little more towards the diagnosis. And, clearly everything is easier in retrospect, as was evidenced by the fact that, we kind of went into this biopsy fairly blindly. And I think we were kind of a little bit surprised. On the same lines, imagine if we would have got the serum immunofixation in the free light chains back before. I don't think, I don't know. We have time to go into this, but I don't think most of us would have done a biopsy because I think you would have gone straight to a bone marrow. You had a diagnosis of plasma cell dysplasia, and the patient would have got it treated. Although there have been, Nelson Lung did write an editorial on that perhaps you still want to do a renal biopsy and know what lesion you're dealing with. But getting back to Steve's point or Casey's point, the treatment's going to be pretty much the same once you find this. So. Great discussion. Thanks, everybody. Great case, Casey, and a nice discussion. I'm glad you didn't do it as an immunofixation beforehand.
Thanks very much, Casey. Great case.
Thank you.
And I want to wrap this up. Thanks, everybody. We will be on again, I believe, next week. Until then, stay safe.